what I see here is, first off, let's look at the position of the condyles in the fossa. Does it make sense? Is there anything aligned at all? No. So here on the patient's right, on your right side, you have a fairly centered condyle head, and on the left, I don't know what. So what does that do when the mandible is misaligned? Let's look at the cervical spine. Wait a minute. Actually, we'll look at it this way. This data is not as good as Denise, unfortunately, but all right. So remember, we're talking about aligning the head over this dens here. We're talking about having balanced equilibrium. Do you have neck pain at all?
I think that's mine. No, more shoulder.
Shoulder. All right, it's going to show up somewhere. So I'm going to show you different ways. I'm sorry, this is not the, apologize. That's not corrected yet. All right, so we'll go into, I apologize. I have it down here. Let's see, so this is Denise. We're looking at Jenny, but I didn't do Jenny's transformed yet. So I'm sorry, we'll go to Denise. I terribly apologize for this. So I do have transformed for Denise. All right, so we'll look at that. All right, so now we have, this is transformed correctly. The other one was not. I was wondering why I didn't see it correctly. So here, all right, so here we have the orthodontist, which is more like what I expect. Here we have the orthodontist actually has centered the condyles correctly in the fossa as best they can. So the orthodontic treatment is designed to do that. However, where does the dens sit now with the position that the mandible is in? Can you see? This is the dens, and this is the lateral. These are the alar ligaments. Look at the space on the right side. The right side has laxity, and the left side is compressed. Can you see that? That this space is great and this space is not. So let's see what that means to the cervical spine. I assume I did that already. I don't know that I did. Let's see. I need Denise and the cervical spine. All right, we'll do it. So very simply, what I'm going to do, this is transformed. I'm going to create the skeletal structure in here so that you can see it. I apologize. I really shouldn't have done it this way. I'm just very upset because both of these ladies have compromised cervical spine. And it becomes extremely opposite, let's see, render. And let's see if we got a good, yeah, that's good. Threshold. I'm sorry. All right. All right, so let's look. First of all, this is the result of orthodontic treatment. Now I'm going to put this line at the center. Yeah. All right, so this is the center where they decided to put the mandible. Docs. This is the center of the lower, the center of the upper, not perfectly aligned, but does it have anything to do, the mandible position, does it have anything to do with the center of the skull? Does it have anything to do with the center up here? How about the mandible position? Is this side up and is this side down? How about the teeth? Were they pushed out? Look at the bone. This side pushed out more. Look at the angle of the teeth. This was developed better. So this side is developed better. There's more bone in here. The teeth are more straight up and down. But whatever Invisalign, whatever was done, slowly moved the teeth. And as I point out, they don't move horizontally. They don't move in 2 dimensions. They rotate. Look at the angle of these teeth. Let's look at the occlusal relationships. So we'll just take this and look at what they did in occlusion. Actually, the total mindlessness of it is very disturbing. See, the thing is, all this orthodontics, what you're seeing, 45 years ago, Bimler did this, and by the way, there's 5 or 6 different ways to do the measurement, which means there's no one way, so no one way is correct. And it's based on 2 dimensions. So what happened to the bite relationship? Don't remember, I've never looked at this, but I just know, look at this. Is this obscene, gentlemen? Is this obscene? Look at this bite relationship. Look how those teeth come together. That's why you cannot do anything without a cone beam scan. You have to look at your patient and do an evaluation. And you don't move the mandible by moving teeth. Look at the result. So, from what I see here, this is Denise. Denise breathed better into the left side. Look at the size of the maxillary sinus. So actually, before her orthodontic treatment, this was well developed. She had a nice crust-to-fossa relationship on that side. But how about giving her a wider smile? So what did they do? They put an expansion device in here, and this proves everything I was saying. This is the better developed side, so if you put an expansion device, that side's going to move more than the underdeveloped side. So this side is rotated so far out, it's almost out of occlusion, that now what they did was, with the expansion, they created a crust-to-fossa relationship on the right side. Bravo. Bravo. This is pathetic. So sad. And now, please stand up. Denise, rather. Denise.
Shoot you. I'm just going to put you out of your misery.
I'm so sorry. I'm really so sorry. So I want to get one of those tongue depressors. So, yeah. So let's take a look at you. We'll take a look at you. Yeah, so, come over a little bit this way. All right. All right. It's hard to see with the lighting. But, so interesting, we looked and we saw better development. So here's what happened. She started out like most of us do with left torsion. This is a little bit wider here with a nice prominent cheekbone on this side. And her mandible was to the left, which is exactly what happens. But when they got done with the orthodontics, they pushed her mandible all the way over to the right side. What does that do to the neck? Well, let's look at your neck. Well, bring your hair back, please. All right. So, where is the set? Look at her left shoulder is higher.
Doctor, can you bring her forward into the light?
Yes. All right, now I got to be able to see too. All right. So, can you face me just a tad? So, All right. So what do I see here? Well, I see that the right shoulder is square, the left shoulder rounded. So basically, she's breathing more on the left side. So also, her head is slightly tilted to the right side. So there's the deal. Her head's tilted to the right side, the right shoulder's square. She's using her right side for support and the left side to breathe. So now, this is my patient. I'm not looking about how to develop her or anything, but right now we want to correct her posturally. Everything, posture, posture, posture. It's not about getting the mandible lined up with the maxilla, because the maxilla could be anywhere. So basically, put your right arm out and resist me, please, as I press down. Strong like a rock. Put your left arm out, resist me. Nothing. So basically, now we just take this, bite down. Now put your left arm out. You ready? Man, she's strong, like a bull. Well, like a cow. No, it's the wrong thing. I'm getting worse at it. I'm worse at it. All right. So now, but what did they do to your cervical spine? What chance do you have of not having pain? What I see here is her head is shifted over to the right side. There's a total imbalance, okay? So now let's look at her imbalance in real life. After we straightened her up, we created this here, didn't we? No, let's do it. I apologize again. So here, we're going to put that in segment, and we're going to look at her cervical spine. I think I did it, but I'll do it again, because we now know that she's shifted to the right side. Okay. Preset, bone, and threshold. And we'll look at the back. All right. My word. So, because of the position of the mandible, because it hurts my heart, I'm not kidding you, because they screwed her up so bad, this is the center of the skull, this is the dens, the center of the skull is to the left of the dens is tilting to the right, C1 is rotating to the right. She basically is C1, C2 instability. And if you listen to the presentation done by Tim Adams, the symptomology that you're set up for is horrendous. Horrendous. And on top of that, you're a dentist, which means that you can't breathe properly, you can't get your head centered correctly while you're working. So what do we call this? So what we call this is a side bend. This is the back, so actually that's not exactly what happened. Not exactly what happened. So let's look at the mandible at the center of the mandible. So the mandible is centered, is rotated which way? Well, here's how we determine it. Look at the space in here. The space in here is wider. This is the right side, by the way, so I made a mistake on the dens here. But here's the real story. So this space is wider, this space is smaller. So the mandible is rotated here, actually rotated to the left on this, and the head is tilted to the left on this. I apologize. I usually spend a lot of time preparing all of this, but the thing that's easy to understand is that this is, there's no alignment, there is a chronic repositioning, and now to prove that it's chronic, we look at the dens to see where the dens is centered or not centered. We'll put it back in display, and we'll look at the back at the cervical spine, and there it is. So I don't get confused now because it says left and right on here. So here we can see that basically her body is shifted to the left side, but the head itself is to the right. So in other words, the dens itself is shifted to the left side, and there's laxity in the right alar ligament. So in any case, we need to get the head aligned, centered and aligned. This only gets worse if she gets a trauma now. Now what you're also starting to see from this, what you start to see is calcification, and hypercalcification. So what you see is that these regions here start to become hypercalcified. Sometimes you see calcification in the space. All right, I'm going to leave this because I didn't do the prep on this. Last night I was up to 3 in the morning with Catherine. So I'm going to show us Catherine. Let's look at Catherine. But there's no doubt that this orthodontic treatment is unacceptable. How can we let this happen? How can we have patients we send to the orthodontist and they do this kind of work? But right now I'm going to go to where I have a more comprehensive presentation. So I'm going to pick up Catherine. I'm sorry. Thank you, Dan. Thank you for your help. Thank you. As we know, we start by looking at the patient posturally. We look at their face, look what their posture looks like. And if you hear Catherine, look, so basically she might be a little higher on the left side, but she's centered pretty good. She might be, left shoulder is a little higher. And basically, so normally what happens, if the left shoulder is higher, what happens is if the left shoulder is higher, then basically you have a tilt to the right side, and then you compensate by bringing your head to the left to level your eyes. This is normally what we see. So when I looked at Catherine, it's really hard to determine which side is less developed. Look how nicely symmetrical she is. So the idea is we make a chimera. Sometimes that'll give us the information we need. In this case here, when I look at her eyes and her brow, this appears to be better. The left face feels to be better developed, the right face less developed. But once again, this is really challenging. So now we look at her this way. So usually this nails it, because here we can see the outline of the facial structure. Here, this is the right side, this is the left side. Look how much better developed she is on the left side. You can see the nice bow of the left side, and you can see the right side is actually pushed forward. It's a little narrow and pushed forward. Now, what's the clincher? The clincher is, how does this development affect the position of the mandible? Well, on the side that's underdeveloped, the mandible is back, and on the opposite side, it's rotated back. So out, rather. So if the right side is back, the left side is rotated out. So this confirms for me that her right face is actually less developed. So, but this is basically what we know about Catherine. What she told me is that she had 3 different bouts of orthodontic treatment. 3 different bouts of orthodontic treatment. So now, what happened, since we know that the right side basically is the less developed side, so what they did was, just like we saw before, they pushed the right side out and moved the mandible to the right. So now what we see here is the position of the condyle on the left is aligned pretty nicely, but the condyle on the right is rotated outward. They created this bite relationship. They moved the teeth. The bone here, the alveolus here is internally rotated. If you look at the relationship of the teeth, which is the opposite of the way she started. This is internally. How do I know it's the opposite? You see these 2 palatine bones? Well, the left one is higher. Her left one is higher. I think if you look carefully, you're going to see the left maxillary sinus is a bit larger. And we already determined that the right side is narrower. So this occlusal relationship was created by the orthodontist. And in order to do it, he shifted the mandible to the right side. But nobody, for example, paid attention to this. This is a lingual tonsil that's compromising breathing. So we do an evaluation, we find a whole lot of stuff. Now, what happened to our cervical spine? So basically, we understand that the mandible is rotated to the right. That's pretty obvious here. From the center, you can see that the left side is rotated out more, and you can just look at the mandible to see that the left side rotated out more, so the mandible is shifted to the right. Look at her cervical spine. Look at the compensation she is. And furthermore, just like I was saying, look at that hypercalcification. Now, Catherine, where's Catherine? I want to know if Catherine had a trauma. Yeah, ask her. So this is classic. I would say, without really knowing, that she had a serious trauma because the weak point is right here, C1 and C2. Look at the hypercalcification. Look at the calcification, the ligament. I wanted to ask you, did you ever have trauma to your head?
I did. I fell on my cheekbones, like off the bike, really hard without breaking my fall off the bike once when I was, let's say, 5 years ago. And then I fell on my head backwards really bad, like in June. That was my latest.
So here you can see it. With that trauma, you develop hypercalcification. This is calcification doesn't belong there. So what happens is the trauma always goes to C1, C2. The trauma, this should be, the ligaments in here are not that strong. So when she traumatized, basically, she traumatized the ligaments, and then all of this starts to become hypercalcified. Now, what happened to her neck based on 3 different orthodontic treatments? This is what's important. This is the key to everything. C1, C2. C2 is the key. It has to be over below the center of the, by the way, the good news here, I believe, let me go back. The good news here is, well, sort of, not really. So, yeah.
It might be on one side or the other because it's hard to see the screen behind you.
Oh, I'm sorry.
Thank you.
Thank you very much for telling me.
Do you want to use that? Like Dr. Adams?
No, I think, am I okay now? Can you see now?
I think
Still?
walking-
Yeah, a little bit more that.
Okay. All right. So, what we look at is the center of the occipital prominence right here. There's the center of the occipital prominence, and we want to see that dens, C2, underneath that. Otherwise, you've got situation like this. Look at the position of her cervical spine. Look at the position of the dens. So basically, this is all under stress and strain now. The upper portion is what we call side bended to the right. Side bended to the right means it shifts to the left and then comes back to the right. So what does that do to the rest of the cervical vertebrae? So we looked at it. So that area behind the soft palate where apnea occurs, that's C2. This is the position of C2. C2 is rotated to her left side. Then I went down a little further, C3, and that's actually rotated to the right side. And then we went down a little further around C3 and look at the position of the airway. The airway is twisted. If the neck is twisted, the airway becomes twisted. So you don't get, she basically now has her head, look at the cervical spine in relation to the center of where she should be. When we get to C4, she shifted all the way over to the right side. So this is my point, folks. Now, how do we correct it? Well, let's look at her airway. Look at the airway. So basically, with the twist that's in the airway, that twist is in the cervical spine, So we showed you basically how to get the head straight. We want you basically to use a pod to decompress the jaw. The musculature will start to align it. When you bite on it, as we show you over and over again, we can basically get the patient balanced and stronger on the correct side. We want you to use the relaxator to work on the airway, because when the airway is expanded, the cervical spine straightens out. So here, it's interesting to see the occlusion here. Basically, we said the right side was less developed. Well, here it's obvious. See, the occlusion on the left side is nice cusp-to-fossa relationship. On the right side, edge to edge. You'll see that with the HomeoBlock appliance, I'm going to give you my final presentation after this, how the HomeoBlock appliance corrects this. So yes, the orthodontist lined up her mandible to her maxilla perfectly straight, but you see the cant. The cant in the maxilla is left torsion. The left side is higher. The left side is higher. That's the left torsion. Left eye should be higher. Left side is higher. The left palatal bone is higher. Basically, the rest is what the orthodontist does. All right, so this is left torsion. This is left torsion. So what we find in left torsion is, because the right side is narrower, you're going to find an eminence on the right side in the frontal region. You're going to find the supraorbital region more prominent on the right side. It's narrow and pushed forward. The eyes slope up to the left. The nose slopes up to the left. So do we have that? Yes. So when we look at Catherine, we see the eyes sloping up to the left from the corner of the eye to the corner of the eye. Her nose slopes up to the left. And basically the mandible we cannot rely on because the orthodontist repositioned it. Now, in relation to the cervical spine, etc., basically the mandible is shifted to the left. That's what nature did. The left ear is abducted and higher, and the parietal and temporal bone, external bone, is greater on the left side. But after 3 bouts of orthodontics, that's not terribly reliable. Yes, the temporal and parietal bone is greater on the left side. The left face is definitely rounder. As far as the ears are concerned, basically, when we look at her ear, yes, there is slightly more abduction. You can see it's rotated actually a little further outward and forward on the left side. There's more abduction. It's slightly higher also, slightly higher. That's your temple bone. So in the region of the petrous portion of the temple bone. So looking at this, we see she has a really nicely developed airway in general, but look at the twist in it. That's what we're treating. Look at the twist in the airway. That's her posture doing that. That's the malposition of the mandible, creating that funky airway, which no longer functions correctly, which affects everything in the entire body. Well, there is some, I'm not going to get into the anterior listhesis. We look at the hyoid position, and by the way, she has some serious swelling at the base of the tongue here. We showed that. We showed that there's swelling at the base of the tongue. So this is the ethmoid and sphenoid sinuses are clear. Turbinates, she has some swollen turbinates. So we're looking at the axial nasal passages, and you can see the inferior turbinate is a little more swollen on the left side. We can still also see that the maxillary sinus is a little better developed on the left side. So when we look down the airway, we actually, with this software developed by the Mayo Clinic, we have something called virtual endoscopy, where we actually can put an eye in the airway and look down the airway. Now we see a swelling at the base of the tongue right here. There it is, you can see it. And now when we look down there it is. That is a seriously swollen lingual tonsil. But it's unilateral, it's only on one side. That's also, I believe, either a symptom of the twisted airway or part of the cause of the twisted airway. So here we look at it again. So what's significant to me, the way I look at an airway, I look at the back of the airway wall. The back of the airway wall in your young folks is going to be flat. That's good muscle tone. Here we have actually a collapsible airway. So if Catherine does not have sleep apnea, she has upper airway resistance, because a collapsible airway at night will produce a sympathetic response, take her from deep sleep to light sleep. What percentage of her sleep is interrupted by that collapsibility is what we treat. We ignore, basically, not ignore, but we're not focused on sleep apnea like the rest of the world is. Sleep apnea is numbers that were created by us. Just like the dentist who does all these measurements and creates a position for the mandible. What does it mean? You created it. Where did you get it from? So basically, sleep apnea, AHI of 5, you got sleep apnea. AHI of 4, you don't have sleep apnea. How ridiculous is that? But what's important is your sleep at night, how you feel in the morning. So the number of desaturations you have, what percentage of your sleep are you fighting for survival? That's what we look at. It's called cycling time. Yeah, so there's the basically swollen. I showed that. So here's the twisted airway. So we're really good at untwisting airways, I have to tell you. So when I get into my final presentation, I'll show you the treatment that we actually do that. I want to get into my final presentation. So I'm going to look at the nasal, basically we're looking at the nose. We always look at the nose. This is known as the external nasal valve. That's fine. She's breathing beautifully. This is the internal nasal valve. This is where you generally see compromise. Not so bad at all. This is the internal nasal valve. This is the inferior turbinate, medial turbinate. They're swollen on the left side, but it's not a big deal. She can breathe through her nose fine. We also look at, remember I said that we have flexion and extension. Well, this is the cranial base. If you look very carefully, this radiolucent line is the junction of the sphenoid and the occiput, and this angle is acute. That's flexion. So that compromises. What does flexion do? Gives you a shorter, wider cranium, hence more of this. When you're in, that's why we see the ears like that. If it was reversed, if this angle was reversed and was an extension, then your ears are tied up against your head because you get a taller and narrower cranium. All right, so from here I'm going to go into my final presentation, which I hope ties it all together and maybe gives you an understanding of how the body does the self-correction. Because I have every kind of cranial strain and I have actual physical proof of what the body does to correct it. I'm sorry. So this is I'm looking for face and airways, breathing, face and airways up, and breathing. Oh, here it is, primary respiratory. All right, so we've been talking about breathing. And as Tim eloquently showed us, breathing is about oxygen, carbon dioxide, and nitric oxide. Fine, everybody can understand that. But what's really important to the body is something entirely different. What's important to your health is entirely different. It's known as primary respiratory function. The world of osteopathy understands that the cranial bones move when we breathe. This contradicts what we've been taught in our dental professional education. The movement of the cranial bones is primary function to maintain our health and well-being. We will prove that the cranial bones move by moving them. It's very simple. So what is 5 primary respiratory functions? Fluctuation of the cerebrospinal fluid, the inherent movement of the brain and the spinal cord, the movement of the articular movement of the cranial bones, the dura, the tension in the dura, and the motion of the sacrum and the ilium. All of this breathing affects all of that. Breathing affects cerebrospinal fluid, the movement of the brain, the movement of the cranial bones, the tension in the dura, and the motion of the ilium and the sacrum. That's really being a doctor. What we are treating is craniosacral dysfunction. It's a somatic dysfunction of the cranium that affects the sacrum. Many of our patients are going to come in and say they have lower back pain, and you can actually treat them. When we breathe, these structures move and one affects the other. So let's look at it. So what we're looking at here is this is the back of the skull, this is the sphenoid, this is the ethmoid, this is the medial cranial fossa. So what I was saying is when we inhale, we do this. We get shorter and wider. Exhale, taller and narrower. Another way to look at it. Well, these are the greater wings of the sphenoid. This is where your orbit is. So when we inhale, we get shorter and wider. So the sphenoid greater wings move out, and when we exhale, they move in. This is an exaggeration of the movement of the sphenobasal synchrondosum. Here's your occiput. Here's your foramen magnum. These are the occipital condyles. The occipital condyles, which basically nobody ever taught you. They're like little legs in front of the foramen magnum. So understand, on inhale, what happens? On inhale, they move forward. On exhale, they move back. That's the key power of the exhale again. The power of the exhale. When we inhale, what's happening, we're actually getting all that tension on our cervical spine brings our cervical spine forward. When we exhale, the rotation, let's look at it again. Inhale, exhale. When we exhale, that brings our cervical spine back and allows us to improve our posture. So how does that affect the rest of the body? So we say inhale is flexion. We showed you that, flexion. And basically that SBS moves in a superior manner. And basically what happens then, your pad bones go into external rotation. Vis-a-vis Catherine. She's in, that angle I showed you is flexion. Hence, the external bones go into external rotation. We're talking about the textural portion of the temple bone where the ears are attached. When they go into external rotation, they go out like this, and they bring the ears forward. So that's flexion. And the sacrum goes into counter rotation. So with inhalation. So we'll show you that. And of course the opposite, in extension, which is exhale, we get an inferior movement of the SBS. We get an internal rotation of the paired bones, and basically we get a reverse movement. We'll show you the movement of the sacrum. Why does the dentist need to understand cranial patterns? Cranial patterns affect jaw position, which in turn affect our neck and our head posture, C1 and C2, and hence our breathing. That's what I'm showing you here. That all this orthodontist doodah has no consideration for ultimately where the mandible is to allow the head to sit correctly on the cervical spine. And there's nothing more important than that. So the body is designed for alternating reciprocal cranial and cervical movement. It's necessary and critical for an optimal cranial respiratory function to occur. Without balanced equilibrium, you're compromised. So adaptation of C1 and C2 vertebrae to compensate for cranial strength and affect the whole spine. Vis-a-vis what we showed. Displacement of the temporal bone causes undue pressure on cranial nerves. Tim showed us that. 9 of which exit close or through or close to the temporal bones. Compression and bone displacement can affect these nerves. This accounts for some of the more remote symptoms that accompany TMJ dysfunction. It's not just the internal situation of the jaw joint we're treating. We're treating all kinds of external symptoms of the jaw joint. This embraces the idea that TMJ function is as much a response to the influence of extrinsic to the joint as disturbances within the joint. When you focus on one thing, position of the condyle in the joint and the disc, you're missing the whole bigger picture. That's why we're here this weekend. That's why Tim put hours and hours and hours into linking everything together. So what are the dental effects? Your dentist. Dental effects are hyperflexion are a result of the premaxillar shortening. The anterior teeth are retroclined. Either a class 2 div2 type is present, or all 4 anterior incisors may be retroclined with buccal displacement of the cuspid. The posterior palate is widened and the palatal contour is flat. So in hyperflexion, you have a compromised airway, but you've got a wide, flat palate in the posterior palate. So what are you going to do? Palatal expansion? Constriction behind the soft palate and base of the tongue is common. Hyperextension. Hyperextension patients are entirely different than hyperflexion patients. The patient that you're normally treating, unfortunately, is a person, a real patient, not what they tell you. They tell you treat a patient with a long, narrow face and a narrow palate. Why? Because they're selling you a palatal expander. The patient you're actually treating is brachiocephalic, and no room for the tongue. And we're successfully treating them because we make more room for the tongue and we allow the body to correct it. So how do you know you're a hyperextension patient? They have a narrow interpupillary width, they have narrow nares, and now you're getting the point. They grew differently. They didn't grow like this, they grew like this, tall and narrow, the ears flat, and they have very narrow nasal passages. They have trouble breathing through their nose immediately. Some of those folks are so compromised that the ENT cannot even fix them. So I am reconsidering MSE if they can show me that you can actually increase the volume in the nose for those patients in hyperextension who can't breathe through the nose. That's a possibility. So you have increased facial height, the ears are flat against the skull, the forehead is narrow and vertical, and C1 is carried posteriorly. That protects the upper airway, sleep apnea happens. If you have a patient that has a sleep and breathing disorder who is in hyperextension, it's either in the nose or the base of the tongue. Okay? Either in the nose or the base of the tongue. Why? Because what controls the position of the mandible? This is basically the cranial base angle. In other words, from nasion through basion, you create an angle. So what happens is, as the occiput comes up, the mandible comes back. Okay? But also, basically, all right, so let's look at the relationship of the, down and back. That's the long-faced patient who has a really high-angle mandible, which rotates backwards because when in hyperextension, what happens is the maxilla generally rotates in extensions. The front of the maxilla rotates towards the center of the body. That's called extension. So what happens in your hyperextension patient, you've got the maxilla rotating down like this. By the way, that's why they have class 3. Because it's not the mandible that's forward, it's the maxilla that's back. But however, when the maxilla goes back, the occlusal plane is like this, and then the mandible develops that really high angle mandible, and now they can't breathe at the base of the tongue. See that? So they don't get apnea behind the soft palate, they get apnea behind the base of the tongue. They're extremely hard to treat because their problem is behind the base of the tongue and in the nose. We can't do anything in the nose much. All right. So basically what we're saying, in hyperflexion, the SBS does this, right? Well, that rotates the sacrum backwards. That's the connection. Inhale, exhale. These bones actually move. So we go into extension, where basically we do this, then the sacrum rotates. Basically, the sacrum rotates. But that's, only, that's not really, when you're involved with that, you're definitely working, into discipline. What are we treating? We are treating what we can fix. What we can fix are habits. The head position that I'm showing, start by looking at the patient, posturally, look at their face, look what their posture looks like. And if you hear Catherine, look, so basically she might be a little higher on the left side, but she's centered pretty good. She might be, left shoulder is a little higher. And basically, so normally what happens, if the left shoulder is higher, what happens is, if the left shoulder is higher, then basically you have a tilt to the right side, and then you compensate by bringing your head to the left to level your eyes. This is what we see. So when I looked at Catherine, it's really hard to determine which side is less developed. Look how nicely symmetrical she is. So the idea is we make a chimera. Sometimes that'll give us the information we need. In this case here, when I look at her eyes and her brow, this appears to be better. The left face feels to be better developed, the right face less developed. But once again, this is really challenging. So now we look at her this way. So usually this nails it, because here we can see the outline of the facial structure. Here, this is the right side, this is the left side. Look how much better developed she is on the left side. You can see the nice bow of the left side, and you can see the right side is actually pushed forward. It's a little narrower and pushed forward. Now, what's the clincher? The clincher is, how does this development affect the position of the mandible? Well, on the side that's underdeveloped, the mandible is back, and on the opposite side, it's rotated back. So out, rather. So if the right side is back, the left side is rotated out. So this confirms to me that her right face is actually less developed. So, but this is basically what we know about Catherine. What she told me is that she had 3 different bouts of orthodontic treatment. 3 different bouts of orthodontic treatment. So now, what happened? Since we know that the right side basically is the less developed side, so what they did was, just like we saw before, they pushed the right side out, moved the mandible to the right. So now what we see here is the position of the condyle on the left is aligned pretty nicely, but the condyle on the right is rotated outward. They created this bite relationship. They moved the teeth. The bone here, the alveolus here is internally rotated. If you look at the relationship of the teeth, which is the opposite of the way she started. This is internally. How do I know it's the opposite? You see these 2 palatine bones? Well, the left one is higher. Her left one is higher. I think if you look carefully, you're going to see the left maxillary sinus is a bit larger. And we already determined that the right side is narrower. So this occlusal relationship was created by the orthodontist. And in order to do it, he shifted the mandible to the right side. And nobody, for example, paid attention to this. This is a lingual tonsil that's compromising breathing. So we do an evaluation, we find a whole lot of stuff. Now, what happened to our cervical spine? So basically, we understand that the mandible is rotated to the right. That's pretty obvious here. From the center, you can see that the left side is rotated out more, and you can just look at the mandible and see that the left side rotated out more, so the mandible is shifted to the right. Look at her cervical spine. Look at the compensation shears. And furthermore, just like I was saying, look at that hypercalcification. Now, Catherine, where's Catherine? I want to know if Catherine had a trauma. Yeah, ask her. So this is classic. I would say, without really knowing, that she had a serious trauma, because the weak point is right here, C1 and C2. Look at the hypercalcification. Look at the calcification of the ligament. I wanted to ask you, did you ever have trauma to your head?
I did. I fell in my cheekbone and off the bike really hard without breaking the wall off the bike once when I was 5 years ago. And then I fell on my head backwards really bad, in June. That was my latest.
So here you can see it. With that trauma, you develop hypercalcification. This is calcification doesn't belong there. So what happens is the trauma always goes to C1, C2. The trauma, this should be, the ligaments in here are not that strong. So when she traumatized, basically, she traumatized the ligaments, and then all of this starts to become hypercalcified. Now, what happened to her neck based on 3 different orthodontic treatments? This is what's important. This is the key to everything. C1, C2. C2 is the key. It has to be over below the center of the, by the way, the good news here, I believe, let me go back. The good news here is, well, sort of, not really. So,
Dr. Belfort,
yeah.
you might be on one side or the other, like it's hard to see the screen behind you.
oh, sorry.
Thank you.
Thank you very much.
Do you want to use
No, I think can you see it?
still?
Okay. So, what we look at is the center of the occipital prominence right here. There's the center of the occipital prominence. We want to see that dens, C2 underneath that. Otherwise, you've got a situation like this. Look at the position of the cervical spine. Look at the position of the dens. So basically, this is all under stress and strain now. The upper portion is what we call side bended to the right. Side bended to the right means it shifts to the left and then comes back to the right. So what does that do to the rest of the cervical vertebrae? So we looked at it. So that area behind the soft palate where apnea occurs, that's C2. This is the position of C2. C2 is rotated to her left side. Then I went down a little further, C3, and that's actually rotated to the right side. And then we went down a little further around C3 and look at the position of the airway. The airway is twisted. If the neck is twisted, the airway becomes twisted. So you don't get, she basically now has her head, look at the cervical spine in relation to the center of where she should be. When we get to C4, she shifted all the way over to the right side. So this is my point, folks. Now, how do we correct it? Well, let's look at her airway. Look at the airway. So basically, with the twist that's in the airway, that twist is in the cervical spine. So we showed you basically how to get the head straight. We want you basically to use a pod to decompress the jaw. The musculature will start to align it. When you bite on it, as we show you over and over again, we can basically get the patient balanced and stronger on the correct side. We want you to use the relaxator to work on the airway, because when the airway is expanded, the cervical spine straightens out. So here, it's interesting to see the occlusion here. Basically, we said the right side was less developed. Well, here it's obvious. See the occlusion on the left side is nice phosphorylation. On the right side, edge to edge. You'll see that with the Homeoblock appliance, I'm going to give you my final presentation after this, how the Homeoblock appliance corrects this. So, yes, the orthodontist lined up her mandible to her maxilla perfectly straight, but you see the cant. The cant in the maxilla is left torsion. The left side is higher. The left side is higher. That's the left torsion. Left eye should be higher. Left side is higher. The left palatal bone is higher. Basically, the rest is what the orthodontist does. So this is left torsion. This is left torsion. So what we find in left torsion is, because the right side is narrower, you're going to find an eminence on the right side in the frontal region. You're going to find the supraorbital region more prominent on the right side. It's narrow and pushed forward. The eyes slope up to the left. The nose slopes up to the left. So do we have that? Yes. So when we look at Catherine, we see the eyes sloping up to the left from the corner of the eye to the corner of the eye. Her nose slopes up to the left. And basically, the mandible we cannot rely on because the orthodontist will position. Now, in relation to the cervical spine, etc., basically, the mandible should have shifted to the left. That's what nature did. The left ear is abducted and higher, and the parietal temporal bone, external bone, is greater on the left side. But after 3 bouts of orthodontics, that's not terribly reliable. Yes, her temporal and parietal bone is greater on the left side. The left face is definitely not. As far as the ears are concerned, basically, when we look at her ear, yes, there is slightly more abduction. You can see it's rotated actually a little further outward and forward on the left side. There's more abduction. It's slightly higher also, slightly higher here. That's your temporal bone. So in the region of the petrous portion of the temporal bone. So looking at this, we see she has a really nicely developed airway in general, but look at the twist in it. That's what we're treating. Look at the twist in the airway. That's her posture doing that. That's the malposition of the mandible, creating that funky airway, which no longer functions correctly, which affects everything in the entire body. Well, there is some we look at the hyoid position, and by the way, she has some serious swelling in the base of the tongue here. We showed that. We showed that there's swelling at the base of the tongue. So this is the ethmoid and sphenoid sinuses are clear. Turbinates, she has some swollen turbinates. So if we're looking at the axial nasal passages, you can see the inferior turbinate is a little more swollen on the left side. You can still also see that the maxillary sinus is a little better developed on the left side. So if you look down the airway, we actually, with this software developed by the Mayo Clinic, something called virtual endoscopy, where we actually can put an eye in the airway and look down the airway. Now we see a swelling at the base of the tongue right here. There it is, you can see it. And now when we look down here, there it is. That is a seriously swollen lingual tonsil. But it's unilateral, it's only on one side. That's also, I believe, either a symptom of the twisted airway or part of the cause of the twisted airway. So here we look at it again. So what's significant to me, the way I look at an airway, I look at the back of the airway wall. The back of the airway wall in your young folks is going to be flat. That's good muscle tone. Here we have actually a collapsible airway. So if Catherine does not have sleep apnea, she has upper airway resistance, because a collapsible airway at night will produce a sympathetic response that will from deep sleep to light sleep. What percentage of her sleep is interrupted by that collapsibility is what we treat. We ignore, basically, not ignore, but we're not focused on sleep apnea like the rest of the world is. Sleep apnea is numbers that were created by us. Just like the dentist who does all these measurements and creates a position for the mandible. What does it mean? You created it. Where did you get it from? So basically, sleep apnea, AHI of 5, you got sleep apnea. AHI of 4, you don't have sleep apnea. How ridiculous is that? But what's important is your sleep at night, how you feel in the morning. So the number of desaturations you have, what percentage of your sleep are you fighting for survival? That's what we look at. It's called cycling. Yeah, so there's the basically so here's the twisted area. So we're really good at untwisting areas, I have to tell you. So when I get into my final presentation, I'll show you the treatment that we actually do that. I'm going to get into my final presentation. So I'm going to look at the nasal, basically we're looking at the nose. We always look at the nose. This is known as the external nasal valve. That's fine. She's breathing beautifully. This is the internal nasal valve. This is where you generally see compromise. Not so bad at all. This is the internal nasal valve. This is the inferior turbinate, medial turbinate. They're swollen on the left side, but it's not a big deal. She can breathe through her nose fine. We also look, and remember I said that we have flexion and extension. Well, this is the cranial base. If you look very carefully, this radiolucid line is the junction of the sphenoid and the occiput, and this angle is acute. That's flexion. So that compromises, what does flexion do? Gives you a shorter, wider cranium, hence more of this. When you're in that's why we see ears like that. If it was reversed, if this angle was reversed and was an extension, then your ears are tight up against your head because you get a taller and narrower cranium. All right, so from here I'm going into my final presentation, which I hope ties it all together and maybe gives you an understanding of how the body does the self-correction. Because I have every kind of cranial strain and I have actual physical proof of what the body does to correct it. One second. So leave this one. I'm looking for space and airway. Breathing, facing airway well. Breathing. Oh, here's primary respiratory. All right. So we've been talking about breathing. And as Tim eloquently showed us, breathing is about oxygen, carbon dioxide, and nitric oxide. Fine. Everybody can understand that. But what's really important to the body is something entirely different. What's important to your health is entirely different. It's known as primary respiratory function. The world of osteopathy understands that the cranial bones move when we breathe, This contradicts what we've been taught in our dental professional education. The movement of the cranial bones is primary function to maintain our health and well-being. We will prove that the cranial bones move by moving them. It's very simple. So what is 5 primary respiratory functions? Fluctuation of the cerebrospinal fluid, the inherent movement of the brain and the spinal cord, the movement or the articular movement of the cranial bones, the dura, the tension in the dura, and the motion of the sacrum and the ilium. All of this, breathing affects all of that. Breathing affects cerebrospinal fluid, the movement of the brain, the movement of the cranial bones, the tension in the dura, and the motion of the ilia and the sacrum. That's really being a doctor. What we are treating is craniosacral dysfunction. It's a somatic dysfunction of the cranium that affects the sacrum. Many of our patients are going to come in and say they have lower back pain, and you can actually treat them. When we breathe, these structures move and one affects the other. So let's look at it. Let's look at it. See if this works. Yeah. So what we're looking at here is this is the back of the skull, this is the sphenoid, this is the ethmoid, this is the medial cranial fossa. So what I was saying is when we inhale, we do this. We get shorter and wider. Exhale, taller and narrower. Another way to look at it. These are the greater wings of the sphenoid. This is where your orbit is. So when we inhale, we get shorter and wider, so the sphenoid greater wings move out, and when we exhale, they move in. This is an exaggeration of the movement of the sphenobasal synchrondosis. Here's your occiput. Here's your foramen magnum. These are the occipital condyles. The occipital condyles, which basically nobody ever taught you, they're like little legs in front of the foramen magnum. So understand, on inhale, what happens? On inhale, they move forward. On exhale, they move back. That's the key power of the exhale again. The power of the exhale. When we inhale, what's happening, we're actually getting all that tension on our cervical spine brings our cervical spine forward. When we exhale, the rotation, let's look at it again. Inhale, exhale. When we exhale, that brings our cervical spine back and allows us to improve our posture. So how does that affect the rest of the body? So we say inhale is flexion. We showed you that, flexion. And basically that SBS moves in a superior manner. And basically what happens then, your pad bones go into external rotation, vis-a-vis Catherine. She's in, that angle I showed you is flexion, hence the external bones go into external rotation. We're talking about the petrous portion of the temple bone where the ears are attached. When they go into external rotation, they go out like this and they bring the ears forward. So that's flexion. And the sacrum goes into counter rotation. So with inhalation. So we'll show you that. And of course the opposite, in extension, which is exhale, we get an inferior movement of the SBS. We get an internal rotation of the paired bones, and basically we get a reverse movement. We'll show you the movement of the sacrum. Why does the dentist need to understand cranial patterns? Cranial patterns affect jaw position, which in turn affect our neck and our head posture, C1 and C2, and hence our breathing. That's what I'm showing you here. That all this orthodontist doodah has no consideration for ultimately where the mandible is to allow the head to sit correctly on the cervical spine. And there's nothing more important than that. So the body is designed for alternating reciprocal cranial and cervical movement. It's necessary and critical for an optimal cranial respiratory function to occur. Without balanced equilibrium, you're compromised. So adaptation of C1 and C2 vertebrae to compensate for cranial strain can affect the whole spine, vis-a-vis what we showed. Displacement of the temporal bone can cause undue pressure on cranial nerves. Tim showed us that. 9 of which exit close or through or close to the temporal bones. Compression and bone displacement can affect these nerves. This accounts for some of the more remote symptoms that accompany TMJ dysfunction. It's not just the internal situation of the jaw joint we're treating. We're treating all kinds of external symptoms of the jaw joint. This embraces the idea that TMJ function is as much a response to the influence of extrinsic to the joint as disturbances within the joint. When you focus on one thing, position of the condyle in the joint and the disc, you're missing the whole bigger picture. That's why we're here this weekend. That's why Tim put hours and hours and hours into linking everything together. So what are the dental effects? Your dentist. Dental effects of hyperflexion are a result of the premaxillar shortening. The anterior teeth are retroclined. Either a class 2 div 2 type is present, or all 4 anterior incisors may be retroclined with buccal displacement of the cuspid. The posterior palate is widened and the palate and contour is flat. So in hyperflexion, you have a compromised airway, but you've got a wide, flat palate in the posterior palate. So what are you going to do? Palatal expansion? Constriction behind the soft palate and base of the tongue is common. Hyperextension. Hyperextension patients are entirely different than hyperflexion patients. The patient that you're normally treating, unfortunately, is a person, the real patient, not what they tell you. They tell you treat a patient with a long, narrow face and a narrow palate. Why? Because they're selling you a palatal expander. The patient you're actually treating is brachycephalic. They have no room for the tongue. And we're successfully treating them because we make more room for the tongue and we allow the body to correct. So how do you know you're a hyperextension patient? They have a narrow interpupillary width. They have narrow nares, and now you're getting the point. They grew differently. They didn't grow like this. They grew like this, tall and narrow, the ears flat, and they have very narrow nasal passages. They have problem breathing through their nose immediately. Some of those folks are so compromised that the ENT cannot even fix them. So I am reconsidering MSE if they can show me that you can actually increase the volume in the nose for those patients in hyperextension who can't breathe through the nose. That's a possibility. So you have increased facial height, the ears are flat against the skull, the forehead is narrow and vertical, and C1 is carried posteriorly. That protects the upper airway, sleep apnea happens. If you have a patient that has a sleep and breathing disorder who is in hyperextension, it's either in the nose or the base of the tongue. Okay? Either in the nose or at the base of the tongue. Why? Because what controls the position of the mandible? Basically the cranial base angle. In other words, from nasion through basion, you create an angle. So what happens is, as the occiput comes up, the mandible comes back. See? But also, basically, all right, so let's look at the relationship of the, down and back. That's the long face patient who has a really high angle mandible, which rotates backwards because when in hyperextension, what happens is the maxilla generally rotates in extension, it's called. The front of the maxilla rotates towards the center of the body. That's called extension. So what happens in your hyperextension patient, you've got the maxilla rotating down like this. And by the way, that's why they have class 3. Because it's not the mandible that's forward, it's the maxilla that's back. But however, when the maxilla goes back, the occlusal plane is like this, and then the mandible develops that really high angle mandible, and now they can't breathe at the base of the tongue. You see that? So they don't get apnea behind the soft palate, they get apnea behind the base of the tongue. They're extremely hard to treat because their problem is behind the base of the tongue and in the nose. We can't do anything in the nose much. All right. So basically what we're saying, in hyperflexion, the SBS does this, right? Well, that rotates the sacrum backwards. That's the connection. Inhale, exhale. These bones actually move. So when we go into extension, where basically we do this, then the sacrum rotates. Basically, the sacrum rotates forward. But that's, that's not really, when you're involved with that, you're definitely working, interdisciplinary. What are we treating? We are treating what we can fix. What we can fix are habits. The head position that I'm showing you, the problem in the neck, the twist in the airway, it's all fixable. This is fixable. These are based on the torsions and side bending rotations that we experience. So we treat left torsion, right torsion, left side bending rotation, and right side bending rotation. So I'm going to give you the shorthand. So the mandible and the tongue is where the posture starts. These muscles are attached to the sphenoid. So we are treating the sphenoid to treat the posture. So let's look at how we treat it. Well, here's your sphenoid, here's your maxilla. Guess what? When you put force on the maxilla, that affects the sphenoid. Basically, all right, so let's look at each one of these patients. So do you understand? This is your guidebook. This is the sphenoid position, tells us the position of the jaw. So this is left torsion, left higher eyebrow, left eye, corner of the mouth up, left ear abducted, you see more, and then the mandible is to the left. This is your guide. This is who they should be without orthodontic treatment. So we put the bite block on the right side to lift the sphenoid. So next, we have right side bending rotation. Yeah, the right eyebrow is higher, the right corner of the eye is higher, there's more cheekbone on the right side, the right ear is higher. By the way, I'm not crazy about the position. This position of the mandible should be basically, this is left side bending. Oh, I'm so sorry. So we did left torsion, and this is left side bending. We didn't talk about that. So this is very interesting. Left side bending is actually when the distance between the corner of the eye and the corner of the mouth on the left side is much smaller than the distance between the corner of the eye and the corner of the mouth on the right side. And really what happens is the maxilla is rotated to the right side, the mandible up on the left side. What really happens when you look in the mouth, and we showed it in one of Tim's patients, the maxilla did not come down on the left side. So basically that's why the corner of the mouth is so high on the left, to create occlusion. The maxilla is way up here. To create occlusion, the corner of the mouth is way up high. So we actually start, because this is the lower side, this is the lower eye, we start with the homeoblock appliance on the left side to help reposition the sphenoid. So I don't want to get too complicated, we just keep that simple for now. Now let's look at the right torsion. Right torsion, here you've got basically the right corner of the eye is higher, the right ear is higher, the right corner of the mouth is higher, and the mandible is rotated to the right side. So you make a homeoblock with the block on the left side. Very simple. This is right side bending rotation. This is a very complicated situation, not as simple as left torsion, but you do end up the same way, where the distance between the corner of the eye and corner of the mouth on the right side is small, left side is much larger. So this is a developmental issue. How do we reach the sphenoid. Well, folks, don't ever forget the maxilla is 2 bones, not 1. We have 2 bones in the maxilla. According to Enloe, they grow downward and forward from the cranial base. One of those 2 maxillary bones don't necessarily grow downward and forward as much, and that's how the jaw ends up and back in the first place. So when we stimulate that side, the underdeveloped side, we are sending information to the sphenoid, the powerhouse. So if we want to develop the left side, we put a block on the left side. This is rotation. That force is a force of rotation on the palate, which is a force of rotation on the palatine bone, which, guess what? Right here, the palatine bone is a force of rotation on the sphenoid, to level the sphenoid. By the way, when we don't develop, you're going to get to look at so many things like Tim. Tim has taken this to a whole new level. You have to understand we breathe through the sphenoid. We breathe through the sphenoid. So basically, these are the openings at the back. These are the nasal choani. And what we have here is 2 different sizes. So you can see how the development affects how we breathe. We're breathing better through this side, less through that side, and that's affected by our cranial development. So that's also part of what we're treating. So understand how this works. Once again, it's about internal rotation and external rotation of the maxilla. So look at the occlusion. Where you develop better, where you breathed into better as a child, that grew up and out, the ear is higher, there's more cheekbone on that side, the face is rounder on that side, and this is the kind of occlusion you can expect. Exactly what you want, costa fossa. On the other side, the palatal bone is down and in, internally rotated. That palatal bone is down and in. Therefore, the occlusion is edge to edge. This is the classic situation, classic. So many of your patients are like this. So what are we doing? We're rotating this whole system up and out, up and out. But the body does it naturally to reposition it. Unilateral forces on the maxilla affect the palatine bone, then the sphenoid, then both palates, then the occlusion, then the position of the jaw. It's all linked together. So, all right, so basically, all right, so I don't want to get too technical. So basically, the tongue is actually the mandible. So these muscles, the geniohyoid and mylohyoid muscles, they are attached to the mandible. They are attached to the tongue. If the mandible's to the left, the tongue is to the left. The mandible's to the right, the tongue is to the right. It's all one unit. You need to understand, for example, how we function with these muscles. This is the most important breathing muscle, the geniohyoid. If we tone this muscle, we protect the airway from collapsing. This is the genioglossus. Look at it. It's a fan-shaped muscle. When you clench and grind, this contracts, pulls the tongue forward. You cannot have an appliance in the mouth, not a sleep appliance, not a grinding, a clenching appliance, where that tongue cannot come forward. And yet the very first sleep appliance, the tap appliance, had this thing in the front where the tongue could not come forward. The appliance we've been using for 100 years. Actually more, since 1901, some say. Doesn't allow the tongue to come forward. So contraction of both genioglossus. Always remember, there's a left and a right. Everything has a left and a right. Our body runs on reciprocal, alternating pressure. That's what breathing is. Reciprocal, cyclical, alternating pressure that goes into all over parts of our body. That's what chewing is. Cyclical, alternating pressure. This is what the body understands. Contraction of both genioglossus stabilize and enlarge the portion of the airway that is most vulnerable to collapse. Relaxation of this muscle and the geniohyoid muscle during sleep will promote obstructive sleep apnea if the upper neck and head are forward positioned. Ongoing contraction of one genioglossus results in inadequate universal airway management, and adaptive activity from both the neck and the hyoid will be needed to breathe. That's what we're treating. And by the way, the unilateral block, a stomatognathous system, is neurologically developed, maintained, and operated through heavy forces applied to both temporal mandibular joints and chewing surfaces, the bicuspid and molars. We need that real work that they do to maintain our system to function. Our palates, both of them, are moved by the sphenoid bone that connects the paired bones of the cranium through the palatine bones and by pattern occlusal interferences. That's what we're doing. That's basically Magoon. He's really, really good to read. All right, let's look in the real life. What about orthodontic toothman? How does it affect the mandible? So this is your typical patient. This is the patient that you see in your office. You send them to the orthodontist. The left side actually is quite nicely developed because this patient breathed better into the left side. Basically, this patient, the higher eyebrow, basically higher eye, whatever, more cheekbone on the left. Breathe in, this is a nice arch, and he's narrow on the right side, so the orthodontist, basically he's this, left torsion, and when you take an impression, but basically, so this is backwards, this is correct. So when you take an impression, this is what I'm talking about. This is the left side. This is what the palate looks like in a patient like that, where the right arch is narrow, which goes to the orthodontist. Now, if you put a palatal expander in there, or you put Invisalign in there, and you're pushing on the teeth, which is what you do, you know, you're pushing on the teeth, which one is going to move first? Look at this. This is ready to move up. This resists. That's exactly what you don't want. But orthodontists are very clever. They take a patient like this, where the right side is edge to edge, and they have basically cusp-to-fossa relationship on the left side. And then they do this. They move the right side out, and they align the center of the mandible. That's exactly what they do. And they go home at night, and they feel wonderful about it. They did a beautiful aesthetic job. But this is the patient. Look at the angle of the teeth. What they've done is they've pushed the right side up and out. Look at the angle of the molar. Look at the occlusion. Left side occlusion is correct. Right side occlusion is no longer functioning. We don't want that. We want the bone to move and the teeth to move with it. So even the ALF, this is a patient that was treated with the ALF appliance. This is the results. The purple shows the change in the bone growth in the maxilla, but both sides moved out. Both sides moved out. And what happened? You get this here. This is what we're talking about, what we're showing you, basically with folks like Denise and Jenny. We're basically seeing this. We're seeing an imbalance in the cervical spine, a malposition of the mandible. And by the way, what we are recognizing basically are these two here. These are the occipital condyles. They sit on C1. So basically, this is the support side. See how nice and straight up and down? That's where the patient is using their support. They're not using this that much. They're over to the head is shifted over to the right side. So basically, the neck is shifted to the right, and then the head tilts to the left to level the eyes. So this is improper palatal expansion, just what we showed. It can be so bad that you only have occlusion on one side. All the forces of occlusion now on one side, that's almost what we showed today. Totally ludicrous, totally ridiculous. So here you have patients with a 4 bicuspid. This patient had 4 bicuspid extraction. Nobody bothered to do a Steiner analysis. A Steiner analysis, the SNA line tells you where the maxilla is. It's a sin if that's lower than 82 degrees to take teeth out. Very simple. So we're going to show you some patients, basically. I don't want to bore you to death with some of this, but basically, here, this is what I was talking about before. What's not considered in the development is the position of the temporal bone. So clearly, the glenoid fossa on the left side here is down, the glenoid fossa here is up. What does that mean? It means the temporal bone is higher on the right side here, the ear is going to be higher, you know, basically. So basically what we have here is the mandible shifted to the right, so it's up and back on the right side, down and forward on the left side. That's after orthodontic treatment, because they centered the mandible in the fossa with no consideration of the temporal bone. So I don't want to bore you, like I said. All right, let's look at James Nestor. He's fun. So basically, I met him in 2017. We spoke on the phone. He had written a book called Deep, about deep divers being able to hold their breath for 10 minutes or more. And he wanted to know why. And why is it? Nitric oxide, the mitochondria. So I explained to him that basically, like, this is Wim Hof. Wim Hof is not a fraud, but he doesn't tell you. All he's doing is using the body's self-corrective mechanism. In other words, whenever you get into cold water, our mitochondria generate mitochondrial nitric oxide synthase and superoxide, which is a waste product. The superoxide, which is basically reactive oxygen species, the most dangerous oxidant the body knows, and yet as soon as we get into cold water, we produce it. When we hold our breath, we produce it. The two things that Wim Hof relies on, getting into cold and holding your breath, produces superoxide. But in a healthy body, that's literally broken down on the mitochondrial level to water and oxygen. Which means when you do that, you get an extra oxygen in every single cell of your body. So when you get in cold water and hold your breath, you can slowly build up your ability to hold your breath for long periods of time, because you're training your body to produce that superoxide and extra oxygen in every cell. So the oxygen you have in your lungs keeps your heart rate and your muscle rate, everything is going, and your ATP is still being generated in the cell, independent of the air you breathed in. So I explained that to him in 2017. He said, we got to meet. He lives in California, I live in New York. So where are we going to meet? Paris. So he and his wife and myself and my wife, we went and met in Paris. We had long conversations, and basically that he relied on some of those conversations in the book. I'm in the book. Breath, basically our relationship is very strong. So he's typical left torsion, his left brow is higher, his left eye is higher. He's got cheekbone on the left side, nothing here. So he sent me this picture 2 years later. He only wore the appliance for 1 year. So initially he was left torsion, left eye higher, mandible to the left. This is what he looked like when I first met him on the left. Just exactly what we expect to see with left torsion. Cusp to fossa relationship on the left side, edge to edge on the right. After 1 year of treatment, he's beautifully cusp to fossa on the right, cusp to fossa on the left. What happened? This is what happened. Nature self-corrected. First of all, his right eye was lower. So look at all the new bone we built. This is basically a superior maxilla in here. That generated new bone. This is sphenoid back here. We lifted the right eye. And by the way, what happened up here is, external rotation of the temporal bone, which brings this condyle back and the mandible back to the right. Remember, he started with the mandible to the left. So the left side came down and it shifted to the right. The left side came down and out. The right side came up and back. And we realigned his mandible. This is where the change takes the petrous portion of the temporal bone, which is between the external auditory meatus and the mastoid process. That's where your ear is. That's the controlling factor of the mandible. All right, so this is what happened in his face. This actually is from 2017 to 2022. So when the forces of occlusion, they go up, as I said, into the maxilla, around the orbit, into the brow. So the changes you get tremendous changes around the orbit. This is what he looked like originally, round face, which is modern man, no bone structure. This is actually 5 years later, where he's got cheekbones that are prominent, and he's got a brow that's extremely prominent. Now, you may not see that, but we looked at the change in the bone. This is after 5 years. He's got so much mid-face development. How do we age? We age when we lose that bone. Well, he's got since from 2018 to 2000, this is, the last scan I had was 2000. I just took one in 2021, 22. He's got all this mid-face bone, and then I proved it using a different software. This basically shows different software entirely, 3D face, and it shows roughly 2 to 4 millimeters change in this purple region, somewhere between 2 and 4 millimeters change. Then I calculated his mid-face volume change, and his mid-face volume change was 15,574 millimeters cubed. To this day, improvement over when he first came and met me. That's a younger face. Now, this is a patient I treated remotely. This is really obviously left torsion. Look at how high the left eye is. Look at the position of the mandible. Look at everything. There's nothing here on the right side. This is before treatment. This is after treatment. This is who he was, left torsion. This is what the body did. You can't do this with any other appliance. It developed the zygoma, the sphenoid, the maxilla, moved the mandible, everything on the right side only. See? The left side came downward, but the right, it shifted to the right side. That's what we did. And guess what? Like I said, that changed his cervical spine. So somebody asked me, is there a link here? Well, he basically initially was using his right side. So this is, this is C2 before, and then its relationship to the center of C3 was misaligned, and now he's basically all lined up. He has another one just like the other one. Look at the difference in the midfield. Look at those cheekbones pop out. Look at his brow pop out. This is where the forces go, in this region, developing the bone. That's the bone that supports your face and prevents you from aging. So basically, he again was left torsion. This is multiple left torsion, because left torsion is the most common you're going to see, by the way. Now look at him. Look at the development. Same story. The maxilla and the teeth moved out on the right side. The mandible shifted over to the right, basically. Here, this is, now this is a left side bend rotation. Now now we went from left torsion to left side bend rotation. See now this, I love this one. This is so clear. As a dentist, it should blow your mind. Because now when you look at this guy's face, you know right away he's left side bend. Look at the distance here, it's much smaller, it's obvious. After treatment, he lined up beautifully. So he was what we call left side bend rotation. So what happened? Look at his maxilla. As I was saying to you, his maxilla never developed down on the left side. See, his maxilla never developed down on the left side. So what really happened is this, you can see the purple, the teeth came down, and the mandible came down and forward on the left side. The cheekbone came out on the right side. He basically repositioned everything. Nature did it. Nature knew exactly what to do, and basically this is what he looked like. I mean, he was extremely high on the left side, and he was down and in on the right. Look at the basically the occlusal relationship. And by the way, he's clenching on that left side. Look at the gonial notch. So this is what happens with patients like that. They're severe clenches. Nobody ever told you this. You know, all kinds of stories about clenching, but nobody told you this. So it's all about rotating the palatine bones. Now, unfortunately, he had a retention cyst. That's not polypoid tissue, and I wasn't able to get rid of it. Retention cysts are benign. They're round on top like that, and they're due to inflammation. Normally, I can make tremendous changes in polypoid tissue, but I didn't change that retention cyst. Also, the position of his mandible changed. Remember, we've been showing these ladies as having their condyles all out of position, and now after treatment, they line up beautifully. Here's a right torsion. Right eye is higher, right corner of the mouth is higher. This is what we're talking about. And this, of course, he needs development on the left side. So that's exactly what the body did. All the teeth came out more on the left side. The maxilla developed on the left side, the zygoma on the left side, maxillary development on the left side, external rotation on the left side, and we basically moved him from right to left to line him up. And basically, this is what happened. It's not that clear, but if you look really carefully, his right side was up and out, which is typical for right torsion. And then after treatment, look how balanced, he's basically much higher on the right, too much force on the left side, but now his occlusion is way more balanced. And what happened in his cervical spine? So here he was misaligned, the center of the occiput and C2 were misaligned. After treatment, he basically was lined up beautifully over C2. This is his airway. How does that happen? Look at that airway development. You can't argue with that. That's virtual endoscopy. That's actually his airway. His airway looked like this, where he was breathing through one side of the airway mainly. This side highly collapsed, this side he's breathing. And then now look at the airway tone and the width of the airway change. Now this guy, a lot of people know. He's my right side bending rotation. This is Tom Colquitt. You can go on YouTube and you'll find 6 hours of Tom Colquitt. One of those presentations is about his homeoblock treatment because we cured Crohn's disease. Why? Well, you listen to Tim. It's all connected, isn't it? By changing the position of his mandible and producing improved autonomic nervous system function, we could change the entire body. He had Crohn's for more than 30 years, and we cured it. So here you can see right side bending. Look, his eyebrow is lower on the right. The distance between the corner of the eye and the corner of the mouth on the right, that's smaller. On the left, it's taller. So basically, his mandible is up and back on the right side. What did we do? Well, this was him, right side bend rotation. This is the bone changes we created. His mandible came down and moved to the left. Here's the actual condyle. This is where he started. This is where the right condyle, it came down as we show you. Sorry. So this is DNA appliance. This patient was given to me because they said, listen, I got good results for this guy. He wore the DNA for 3 years, so here's before and after. Tell me what happened. You know, so I went and took a look at his palatal expansion and why was he a successful patient? Well, when you see the pattern of development, he grew his whole maxilla bigger. He basically came out more on the right side. Mandible came out more on the right side, repositioning the mandible. So his right side came out. You can see that. This was him before he started treatment. Look at that. He basically was shifted all the way over to the left. Now, after treatment, 2020, he's perfectly aligned. What happened to his airway? This is what his airway looked like. That was 2017, yeah. So his airway looked like this. He's breathing only through the left side of the airway in 2017. And then we basically got his head on straight. Now he's breathing through the entire airway, and he has 14,152 millimeters cubed of new airway space, for God's sake. So he's doing better. So this is mandibular repositioning after 12 months. This is basically patient showing the changes. This is after 12 months, tremendous changes in repositioning of the mandible. Basically, you can see that this is a left torsion patient. So look at the ear, abducted ear on the left side, basically internally rotated on the right. And what do we see after 12 months? We said, look at the ears. So we repositioned the temple bones. Look, everything changed. That's an increased hat size, for God's sake. So here's the original condyle for that patient. The jaw was misaligned. And now look how nicely centered the jaw is, created just by the body. Here's the right condyle, where it looks like nothing hardly happened. Actually, it maybe even looks like the joint space got a little bit smaller, which it could have, but it remodeled. And look at the left. The left side now is the key. The left side was a mess because the mandible was rotated out of position. Now look at that condyle after treatment, 12 months. Look at the airway. This is a collapsible airway with no tone in the posterior wall. This is upper airway resistance. Here, after 12 months, you see how the airway has toned, become more symmetrical, and even the epiglottis is more level. Everything is balancing. So here's your twisted airway story. Here's the patient before treatment. Look at the ears again. Look at the abduction on the right ear more and the left ear higher. The corner of the mouth up on the left. Now the ears are leveled out, basically. So we got external rotation of the temple on the right side. We got the mandible to center by moving to the right. Here's your petrous portion of your temple bone. Look at the change there. That's classic. That's classic external rotation to reposition the mandible. And here she is. So look at the Kakar occlusion when she started, internally rotated. And here, look at the occlusion after. The occlusion makes sense now. This is what she looked like before. This is what she looks like after. And her airway was very floppy. Now it's toned. Here's the difference in the airway, the twisted airway. And now the airway is no longer twisted. So we can see before and after the airway is not twisted. This is the body self-correcting. This is the region at the base of the tongue. This one was behind the soft palate. This is the region at the base of the tongue. That opened up really nicely. So here's her actual airway. So her axial airway improved, you can see before and after. Her AP airway improved, the axial airway. Now, why is the posture important? Well, here's a classic homeoblock case. What did we do? Looks like we developed the left side on this patient. A lot of development on the left side. The patient's wearing a pod, by the way, at this point. However, the purpose of this was to look at the airway before and after. So initially, he was breathing only in the left side. After he expanded his airway, he's breathing through both sides. The size of his airway, immensely improved. So here we have neurocranial homeostasis and alignment of the mandible. Oh, by the way, you've seen so much, but this is really what we're talking about. We're talking about really creating changes in the temporal region. So I kind of looked at it in all different angles, seeing that there was change in the temporal region. And then you see the repositioning of the mandible. Look how screwed up, excuse my French, her neck is. Look at that. So it's starting to correct. Things are starting to correct. This is how much change we got. Monstrous. And then I confirmed it using different software. So we got all this bone growth and repositioning in this region, the mandible coming to the right side. And here it shows pretty much the same thing using a different software. This is to confirm it. And what happened? Well, look at the balance of the occlusion. Look at the palatal position. We reposition the palate, the maxilla. And now, how do we see this patient differently? Well, this is 3D MD face. This is an accurate facial photo. Here, the left eyebrow is higher, and left eye much higher. Here, look at them. Look at the cheekbone development, the symmetry in the mouth, the alignment in the mandible. Here, the mandible was to the left, more cheekbone on the left. And does she look younger? Yes, she looks younger. This is her before and after. And basically, posturally, yes, she basically was pretty bad. The spinous process is C1 up against the occiput pretty much. This is her head posture. This woman said, I've been complimented on my posture all my life. Look at her shift of her head to the right side. And by the way, look at the rotation of the shoulder. Look at the clavicle. She shifted over the right side to breathe. She's using her secondary breathing muscle. Look at the clavicle pop up. Look at her shoulder rotated forward. Look at her head shifted over there to breathe. This is what she looks like now, centered. This is what we're treating. Now, this is my favorite. Because in some of these cases, this is a woman that had hardly any cranial strain at all. Tim. Hardly any cranial strain whatsoever. However, she had some of the worst polypoid tissue in her sinuses I've ever seen. So basically, this is, I'm beating the cart in front of the horse here. So basically what happened here is I couldn't treat her, I thought, so I sent her to the surgeon. I want you to show you what the surgeon does. The surgeon was brilliant. The surgeon did an extremely brilliant job. So the green is the before. Reamed out the ethmoid, took out all of this polypoid tissue, but my experience is it grows back. So ultimately, this is still polypoid tissue here, okay? Probably did a soft tissue ablation on the turbinates, but this is still polypoid tissue. This is what she looked like. Oh, I'm sorry, I didn't show you that. She originally looked like, she had 2 surgeries. So the first, this is what she looked like. She had her ethmoid sinus was completely inflamed. She had stenosis of the turbinate, so she couldn't breathe properly through her nose. She had so much polypoid tissue in her maxilla, you couldn't even see an airway space. So she had surgery, and then this is the surgery, the polypoid tissue grew back. So what you see here is the second surgery, which was done brilliantly by my friend. However, she went from this to this with the surgery, but with the Homeoblock appliance, she still had all of this and it gone. Not only with the Homeoblock appliance is she completely clear of anything, she's starting to grow back her medial turbinate. So all this green went away with the Homeoblock appliance. All this green went away. So now she went from this to this. There's not a drop of polypoid tissue in her sinuses whatsoever. How do we do that? Here's her ethmoid sinus before and after. Here's just another one just to show you. Here, this fellow is left torsion, his right condyle's back, left condyle abducted. Look at all the polypoid tissue. He's left torsion, as we show. This is his face before and after. Now he's symmetrical. We created this change, but look at the change in the polypoid tissue. Shrunk the polypoid tissue. How do you do that? What causes the growth of polypoid tissue? It is a totally predictable pattern that I have all the citations for. I gave a presentation to 31 doctors at Montefiore Hospital in the otolaryngology. I gave a presentation with all the citations. I just don't have the time to give it. What happens with your patients, by the way. What the surgeon is doing is treating the symptoms. He's reaming out the ethmoid. He's taking out that polypoid tissue, but he's not treating the cause of the problem. The cause of the problem is in the airway. The collapsed airway creates negative pressure. You get acid in the superior esophageal sphincter, known as pharyngopharyngeal reflux disease. That creates inflammation. It goes everywhere. It goes in the back of your throat, into your nose, into your sinuses, into your ears, into your lungs. When it gets into the sinuses, it causes inflammation and it closes off the opening from the nose into the sinus. So when you breathe oxygenated air, that oxygen doesn't get into the sinus. Now you have a hypoxia in the sinus, and guess what the hypoxia does? It changes the lining of the sinus from epithelial to a mesenchymal lining. And now all you need is what? Eosinophils. You don't know what they are. Well, we have immune systems. You were only taught in dental school the Th1 system, where you get a bacteria in the nose. What the body will do is create inflammation and send white blood cells called phagocytes basically to the white blood cells, come and they kill the bacteria. However, the body will not deal with that inflammatory response more than 12 weeks. It's got to shut down. It's no longer going to do that anymore because it didn't work. You still got the problem. So you shift from a Th1 response to a Th2 response. So basically that's different cytokine signaling in the body takes place, and the body generates a more powerful killer. It's basically an eosinophil, which is a beta cell, I believe, eosinophil. And once that gets into that sinus with that mesenchymal lining, it's so powerful to kill the bacteria, but it grows the polyps. So we know exactly what happened. When you see all that polypoid tissue, we know that that sinus had an hypoxia for 12 weeks or more. That patient had chronic rhinosinusitis for 12 weeks or more. That's the only possible way you can grow the polyps. The cause of the problem is two things: the airway tone, which is collapsible, which we treat, and the openings between the nose and the sinus, which are too small. When we grow the maxilla, those openings get bigger, and now the oxygen gets into the sinuses, and this is what we're capable of doing. All right, my friends, this was my, basically my capstone presentation. I'd like to entertain questions, and I hope you got my point here. It's an entirely different approach. Thank you. So it's body healing the body, which, by the way, is supposed to be the 21st century. I heard that in the year 2000, the then Surgeon General, who basically opened the door for dentists to do all this medical treatment, in 2000, the Surgeon General is who said that the dentist is the doctor for, and he gave a whole list of things, which is pretty much the whole region here. It's not teeth and gums anymore. That changed in the year 2000. That same Surgeon General said, this is now the 21st century, and we are in the age where the body is going to heal the body. And of course, what they were talking about was the Human Genome Project, where they were certain we're going to be able to switch off the genes for cancer. We're going to be able to switch on genes, switch off genes, and we're going to cure cancer, the age of the body healing the body. And of course, that didn't happen, but we still are the age of the body healing the body. It's just that the orthodontic community is 100 years behind the time. So I know I offended people. Yes. I did. Tim?
Yeah, great job. I just wanted to ask, have you ever put the block on the wrong side?
Yes, a lot of times.
Can you talk a little bit, is it self-limiting or does that cause further asymmetries, further?
Actually, it doesn't really make that much of a difference. You still get the same results because the body knows what to do. So you're still doing the same signaling to the body. You're still signaling the DNA. you're still getting upregulation. You're still getting the changes. I've done many times, I've done a mistake, and it didn't make that much of a difference, quite frankly. Where it makes a difference is very simple. It makes a difference not in left torsion or right torsion. It makes a really big difference in the side bending cases. In the side bending case. You have to understand, right side bending rotation. Oh, let's go there. That's a wonderful question. Why is that so horrendous? Okay? And I wanted to demonstrate it on the two ladies here. I didn't really get to it. So basically, most of us develop our left side, jaw to left. And guess what? The heart is up here on the left and the liver on the right. Our society is designed for those folks. That's the majority of us. Another way, in other words, the brain is going to center the body. The heart is on the upper left, pulling us forward. So what does the brain do? It brings us back here on our right foot. We're centered now. This is natural posture for left torsion with the weight on the right foot, which basically allows us to open doors. Open doors. It allows the body to rotate. It allows the body to rotate correctly. As soon as the mandible goes to the right side, we now have to shift to our left side. And the body has a really tough time trying to use that right hand, which is the right hand society. Actually, in my presentation, I showed that there are more nerve fibers in the right arm, basically, because we use the right side so much more, that we're conditioned to be right side. So there is a difference in our balance between somebody who the jaw is shifted to the left and somebody whose jaw is shifted to the right. When you shift the jaw to the right, you do damage. You do more damage to the body. So when you have a right side bend rotation where this is really up and like this, you are going to see serious problem, serious issue in the neck. Hence, if you put the block on the wrong side, you might cause a problem. So that's the only tricky one, pretty much. Yeah.
So when you have a patient who has had an SFOT or MMA, in your estimation, what does that do to the cranial respiratory rhythm?
I'm sorry, say about the cranial respiratory rhythm?
What do those surgeries do to the cranial?
Oh, well, I've got patients referred to me that had beautiful MMA surgery because all they're looking at as the repositioning the maxilla. They're forgetting about the tongue. I actually had one referred to me that needed a tongue release. They did an MMA surgery and the guy felt like crap because nobody ever bothered to release his tongue. So he had beautiful repositioning of the maxilla. He beautifully opened up the space behind the soft palate, but nothing happened to his tongue, even though they actually, they did a surgical repositioning of the mandible. But surprisingly enough, that tongue was still damn in that airway. So you have to look at a complete picture. Each patient is individually evaluated for their treatment plan. Most patients need to do, according to Stanford Medical Center, before you do MMA surgery, you have to try everything that's humanly possible to improve that patient airway and breathing. That's what we do. And when we do a patient, we look at that SNA line, basically the Steiner analysis, and they're down at 74. I've actually had patients like that which had still enough airway. The key element here, which is forgotten because we go by the numbers, that was a 74. It's supposed to be 82. Everybody's going to say you got to go to MMA. Why? Because that patient had enough room behind the soft palate. The only reason to move that maxilla forward, because we can do whatever we want with the mandible, we can do an MAD. The reason to move the maxilla forward is if when you don't have the room behind the soft palate. How do we get the room behind the soft palate? Is posturally. We work with a PJ. We work with PJ. Get the head back and we open up that space, and then we don't send them for MMA surgery. Yeah.
I don't think I articulated my question accurately enough.
Oh.
I'm referring to cranial respiratory rhythm, not pulmonary respiratory.
Oh, okay. So that's very interesting. I'm not an osteopath who feels, the upledger technique. I don't feel the cranial movement. I have really little interest in feeling that movement. I basically believe that we as dentists, we control posture because we control the tongue and the mandible. That's my position. And the way we control the tongue and the mandible is through the cranial system. Now, if they do MMA surgery without treating the cranial system, you're going to have problems, of course. But after they come back with the surgery, you can put in a homeo block and start to work on the cranial bones.